So if you spend, any time at all on the internet looking into firearms or self-defense or ballistics, you know exactly what the landscape looks like out there.
Oh, yeah. It is incredibly noisy.
Right. It's just so loud. You always have that one guy furiously typing a, like, 10,000 word essay at 3 in the morning about velocity thresholds and stopping power.
Acting like the human body is just made of pure math.
Exactly. It's highly opinionated, and honestly, a massive chunk of it is driven by just, well, marketing slogans from the side of ammunition boxes.
Yeah, that's a huge part of it.
But, when you step away from the forums and you actually walk through the sliding glass doors of a trauma bay, all that internet noise just instantly disappears.
It really does. It's completely irrelevant in there.
Yeah, you are just left with this silent, incredibly complex, and totally unforgiving reality of human biology. I mean, trauma surgeons do not care about the brand loyalty stamped on a brass casing.
No, not at all. It really is a jarring shift in perspective when you look at it from the clinical side.
I can imagine.
Because the human body doesn't read those caliber debates. When a projectile enters tissue, the body responds to exactly three things: physics, anatomy, and biology.
Just those three.
Right. A bullet is just a tool delivering energy. That's it. And the tissue it interacts with, well, that has the final say in what happens next.
And that biological reality, that's exactly our mission for this deep dive today. We are stripping away the myths, the slogans, and all those late-night forum arguments.
Getting right down to the actual science.
Right. We're pulling from this really brilliant August 2026 piece from Valortec. It's titled Gunshot Wound Ballistics. Caliber is not a diagnosis.
It's a fantastic article.
It really is. It was written by Herfel, who is a distinguished firearms instructor, and it takes this strictly clinical, scientific look at trauma, mechanics, and the heavy responsibilities of training.
And just to set the stage for you listening, this deep dive is completely agnostic about the politics of firearms.
Yes, absolutely.
Right.
We have to make that clear.
Right. We are taking a purely mechanical look at the reality of the wound itself. We're not endorsing any political stances. We're just looking at the source material rather than the mythology of the tool that created the wound.
Okay, let's unpack this. Because to really understand ballistics, I feel like we have to start by completely throwing out the most common visual misconception we all carry around.
Which is?
Well, we have to stop treating the human body like a flat, two-dimensional paper target.
Oh, right. Yeah, that's a huge issue.
People talk about shot placement like they are punching a clean, perfectly circular hole in a piece of cardboard.
Which is just a dangerously incomplete way to visualize trauma. I mean, obviously anatomy matters.
Yeah.
Where the projectile enters is the starting point.
Yeah.
But discussing placement as just a two-dimensional dot completely ignores what happens, like even a millimeter beneath the skin.
Yeah, and the text highlights this incredible phenomenon where you can have two entry wounds that are maybe, I don't know, a couple of centimeters apart on the surface of the skin. Yet they result in radically different medical outcomes. Like one patient is treated and discharged, and the other is literally fighting for their life in the ICU.
Because it's not a dot.
Exactly. It happens because a gunshot doesn't just create a hole, it creates a three-dimensional track. The term the article says we really should be using is the wound path.
A wound path tells the actual story, When a projectile enters the body, it's not just flying through empty space.
Far from it.
Right. It is traveling through a really dense, highly chaotic environment. It hits subcutaneous fat, it hits fascia, it punches through muscle fiber.
Scrapes past blood vessels and nerves.
Exactly. It encounters organs, it strikes bone. The wound path dictates which specific tissues were forced beyond their physical ability to recover.
And I really want to dig into that physical damage because the article outlines two main wounding mechanisms along that 3D path.
Right, the permanent and temporary cavities.
Yeah, and the first one makes intuitive sense, right? The permanent cavity. That's the tissue physically crushed, cut, or torn by the projectile itself. It's the permanent hole left behind.
The structural damage.
Exactly. If that direct track happens to intersect a major artery, the result is catastrophic. But if it threads the needle and stays in less vulnerable soft tissue, it might be highly localized.
And the essential takeaway there is that the caliber label on the box didn't magically decide which structural anatomy was crossed.
The path did.
The complex 3D path did. In many conventional handgun wounds, this permanent cavity is actually the dominant mechanism of injury.
But then we get to the second mechanism, and this is where I think the internet ballistics community really just loses its mind.
Oh, absolutely. The temporary
The
cavity.
temporary cavity. We've all seen those dramatic slow motion videos, right? A block of clear ballistic gel just violently expanding, pulsing, and wobbling after a bullet passes through.
It makes for great YouTube content.
It really does. It looks like total, unmitigated devastation.
Yeah.
But I want to push back on what we're actually seeing in those videos for a second.
Sure.
Is the temporary cavity just like, okay, think of a powerful shockwave passing through water. It looks terrifying on a high-speed camera, but once the water settles, there's no permanent hole. Is it like that?
Actually, that is a fantastic analogy. The temporary cavity is essentially a brief, violent radial displacement of tissue outward from the projectile's path.
Okay.
But your water analogy highlights the exact nuance we have to understand here. Displacement only becomes permanent damage when the tissue being moved is stretched beyond its specific mechanical tolerance.
Beyond its tolerance.
Yeah.
So the damage entirely depends on what kind of water that shockwave is moving through, so to speak.
Right, exactly.
Like if it's passing through highly elastic tissue like skeletal muscle or lung tissue, it can stretch violently, deform to accommodate that temporary cavity, and then just snap back into its original shape without widespread cellular tearing.
It recovers. The temporary cavity collapses, and the permanent structural damage is minimal compared to the visual spectacle you saw in the slow-motion video.
Wow, okay.
However, if that exact same shockwave passes through tissue that is less elastic, highly organized, dense, or confined,
Like what?
well, think of the liver, the spleen, or the brain. Those organs cannot stretch. When you subject a dense organ like the liver to rapid radial displacement, the cells physically rupture.
Oh.
Yeah, the tissue tears, it fractures, and it hemorrhages massively.
Meaning a massive temporary cavity in an elastic muscle might look terrifying on camera, but actually result in a relatively localized permanent injury.
Exactly.
But that same cavity in a liver is just devastating.
Which is why there is no honest universal velocity threshold that magically converts every temporary cavity into the exact same injury.
Even though people want one.
Oh, people desperately want a neat mathematical formula, but the tissue itself always dictates the outcome.
Which leads us directly into the physics of energy transfer. Since a bullet can, zip right through elastic muscle without doing much beyond its direct path, it forces a pretty terrifying question.
What happens when it hits a tissue that has zero give?
Right. We all know velocity plays an outsized role in the kinetic energy equation, right? But mathematically, carrying energy into a target isn't the same thing as transferring it, is it?
No, and it is a fundamental confusion in the ballistics world. I mean, a projectile can enter the human body carrying a massive amount of kinetic energy, zip completely through a limb, and exit the backside carrying a huge portion of that energy away with it.
Taking the energy with it.
Right. It had high velocity, yes, but it didn't transfer all of that energy into the surrounding tissue.
So the energy transfer only really happens when there is local force and resistance that decelerates the projectile.
Yes.
So we're talking about things like the bullet deforming and expanding or yawing.
Yawing, meaning it destabilizes in fluid and turns sideways, presenting a massive surface area.
Right, or even fragmenting into multiple pieces. That resistance is what actually dumps the kinetic energy into the body instead of taking it out through the exit wound.
The projectile's profile, its stability in tissue, its construction, and the angle of impact entirely change how it interacts.
So broad marketing labels like high velocity might be useful for putting boxes on a shelf.
But they are terrible for clinical diagnosis.
Yeah, the article uses a brilliant physical analogy that really cemented this for me.
The tool analogy.
Yes. Okay, so imagine you are holding a heavy steel tool. If you drop that exact same tool with the exact same gravity onto a thick rubber mat, it just bounces.
Right.
But if you drop it onto a pane of glass, the glass completely shatters. Same weight, same energy, totally different result, purely based on the material receiving the energy.
And human tissue behaves the exact same way. Skeletal muscle, skin, lung, brain, and cortical bone absolutely do not share the same density or tensile strength.
Not at all.
So when people online argue like these two rounds do the exact same thing, they are making a scientifically incomplete statement because they are completely ignoring the material receiving the impact.
They aren't asking the right question. The scientific question isn't just, what does this caliber do? It has to be, through what tissue?
Exactly. Without answering through what tissue, you aren't doing ballistics analysis. You were just reciting marketing copy.
Okay, here's where it gets really interesting. Since tissue density dictates how energy is transferred and how much damage is done, we naturally have to look at the densest, most unyielding tissue in the human body, bone. If you talk to orthopedic surgeons who actually have to rebuild these limbs, like Dr. Chris Raynor, who is heavily cited in the text, you realize the whole caliber debate completely misses what happens when a bullet meets bone.
It changes everything.
This is where a simple entry and exit wound becomes a massive, complex, reconstructive nightmare.
This is a crucial area where the two-dimensional paper target mentality falls completely flat. Well, when a projectile strikes bone, the wound is no longer defined just by the bullet. The bone itself can crack into two clean segments, which is a transverse fracture. Or, with enough transferred energy, it can completely shatter into dozens of fragments.
And that's a comminuted fracture.
Exactly.
And those bone fragments literally become secondary missiles, right?
Yes, they do.
They get driven outward into the surrounding muscle, nerves, and blood vessels, just massively enlarging the zone of injury. But what really blew my mind reading this piece was the biological crisis that happens next.
The periosteum.
Yes. I always thought of bone as just a piece of dead structural chalk inside the body, but it's actually wrapped in this living vascular tissue called the periosteum.
And the periosteum is everything when it comes to recovery. It is a thin, highly vascular layer of connective tissue that covers most of your external bone surfaces.
Why is it so vital?
Because its intercellular layer contains the progenitor cells, the cells that actually form new bone to heal a fracture. It also houses a rich vascular network that supplies blood directly to the outer layers of the bone.
So it's essentially the biological scaffolding in the supply line that allows a broken bone to knit itself back together.
That's a great way to put it.
And if a high-energy gunshot strips away or crushes that periosteum and destroys the surrounding soft tissue, those shattered bone fragments lose their blood supply.
And they die.
They die. There is a line in the text that hit me incredibly hard. It says, "The hardware can hold a structure in place. It cannot make dead tissue alive."
That's a chilling reality check, isn't it?
It really is. It forces you to realize that survival is not the same thing as recovery.
It's a vital clinical distinction. I mean,
Yeah.
you might survive the initial blood loss of the gunshot wound. You might make it out of the ICU. But if the periosteum is destroyed, that fracture isn't going to heal on its own. You're looking at delayed union or non-union, where the bone just refuses to fuse, severe deep tissue infections, and progressive bone loss.
So fixing the bone with titanium plates and screws, the hardware is essentially just geometry.
It is entirely geometry. The tissue viability of the biology determines if that geometry will ever become a living, functioning limb again.
Wow.
True recovery could mean multiple surgeries over several years, external fixators, bone grafting harvested from your hip, and just permanent, life-altering disability.
Which makes you realize how utterly fragile the whole human machine is. And it makes me ask a major question.
What's that?
If the microscopic biology of blood supply, bone fragments, and the periosteum is so critically important to understanding how these wounds actually function in the real world, why is the internet so obsessively focused on shooting blocks of jelly?
The ballistic gelatin obsession, it is ubiquitous.
Right. I mean, I get that the article points out ballistic gelatin isn't fraudulent. It has a real engineering purpose as a standardized tissue simulant.
Yes, it's highly controlled, which lets you repeat tests and compare penetration depth or bullet expansion in a laboratory setting without other variables getting in the way.
And for that specific, narrow purpose, it is highly valuable.
But this raises an enormous problem. What happens when we start mistaking the gel block for a human patient?
Right.
It is a massive category error that plagues almost all amateur ballistics testing.
Because gel has no blood supply.
No blood supply, no
No.
periosteum, no cortical bone to shatter into secondary missiles.
Right.
It has no superficial fascia, no dense organs to rupture, and absolutely no immune response. A block of gelatin cannot get infected, and it certainly cannot heal.
It's just uniform density all the way through?
Exactly. Gelatin can tell you how a bullet deforms and how deep it goes in a perfectly uniform synthetic medium.
But that's it.
That's it. It cannot tell you if a human limb will function normally in 2 years, or if the patient will need an amputation because of a bone infection. Treating a gelatin block as a complete predictive model of human trauma is simply not science.
Okay, so if we can't fully rely on gel blocks to tell us about survivability, we should obviously look at real hospital data, right? Real human outcomes.
You think so?
The text brings up what it calls the hospital data trap, and I want to play devil's advocate here for a second to really test this logic.
Go for it.
They mention a 2024 study from the National Trauma Data Bank looking at intracranial gunshot wounds, so gunshots to the head.
Right, I know the study.
The data showed a 35% in-hospital mortality rate for long guns, like rifles, versus a 43% mortality rate for handguns.
Yes.
Doesn't that raw data objectively prove that handguns are somehow more lethal to the brain than rifles? The numbers are right there in a peer-reviewed database. 43% is undeniably higher than 35%.
It is the perfect statistical trap, and it thoroughly demonstrates why you have to read medical data with extreme caution and understand the mechanics of trauma care.
Okay, how so?
The absolute crucial qualifier in that study is the phrase in-hospital mortality.
Meaning, the patient had to actually survive long enough to make it through the hospital doors to be counted as a statistic.
Which is a textbook example of survivorship bias.
Oh.
Victims of long gun wounds to the head suffer such catastrophic kinetic energy transfer and structural disruption because of the physics we just discussed that they often do not survive long enough for the ambulance to even arrive.
That makes so much sense.
They certainly don't survive long enough to reach the trauma bay and be entered into the hospital's database.
Oh, wow. So the 35% mortality for rifles isn't because the rifle is somehow less lethal. It's because the people who were hit by rifles and died instantly at the scene aren't in the data set at all.
Exactly.
The hospital only sees the anomalies.
Precisely. The data only looked at the incredibly unique subset of long gun victims who miraculously survived the pre-hospital phase, perhaps because of a glancing blow or a massive distance factor.
But people try to fix that with stats, right?
Yes. The people studying this data often try to use statistical methods like propensity matching, essentially trying to statistically balance two unequal groups of patients by matching their baseline characteristics to make the comparison fair.
But you can't propensity match a ghost. You can't statistically fix data that simply doesn't exist because the patient died on the sidewalk.
You cannot. The number in the study is mathematically real, but the lazy internet interpretation of it, that handguns are deadlier than rifles, is completely false. It ignores the logistics of emergency medicine.
That is wild. It really shows how easily statistics can be weaponized in these debates if you don't understand the underlying biology and the realities of pre-hospital trauma care.
Oh, absolutely.
People will grab a single percentage from an abstract and use it to win a forum argument, completely missing the grim reality behind the numbers.
Anyone claiming they have a precise universal mathematical multiplier for exactly how much worse one caliber is than another is selling you a level of certainty that clinical evidence simply cannot provide.
Right.
The variables of the 3D wound path and tissue density are just too chaotic.
So what does this all mean? Bringing this all together, we've moved from replacing 2D paper targets with complex 3D wound paths.
Yes.
We've explored the physics of energy transfer, how a bullet through elastic muscle is totally different than a shockwave tearing through a dense liver.
Right.
We've looked at the living biology of bone and the periosteum, and we've navigated the dangerous statistical traps of hospital data and survivorship bias.
There's a lot to take in.
It really is. So what is the ultimate real-world application for the listener? If someone is listening to this because they want to be a responsible, well-informed citizen, a concealed carrier, or just someone who understands the medical reality of the world, what is the core takeaway?
The core takeaway from all of this science is profound accountability.
Accountability.
Yes. This entire deep dive isn't about giving you a specific ammunition brand recommendation to go buy. It is about deeply understanding that you own every single round.
You own its entire 3D path.
You own its path. You own the kinetic energy it carries. You own how that energy transfers. You own the bone it might shatter. And you absolutely own the permanent, life-altering disability that can result from it.
Yeah.
A poorly justified decision to pull a trigger isn't an abstract error on a paper target. It is a biological catastrophe that cascades through a person's entire life.
The article frames this so perfectly. Training is not entertainment.
No, it's not.
It is not some costume-driven performance for social media where you obsess over gear and velocity stats. True training is the disciplined, serious development of safe handling, sound judgment, and lawful restraint.
Because a life can be permanently altered or ended in milliseconds. The margin for error is microscopic.
Truly.
When you actually understand the science of the wound, when you understand how fragile the human machine is, you understand the immense weight of the responsibility.
I want to thank you for joining us on this really intense, science-driven deep dive. We've covered a massive amount of ground today, pulling apart the physics and anatomy that actually matter when things go terribly wrong.
It was my pleasure. And as we wrap up, there is a final thought I want to leave you with, something that builds on this entire conversation.
What's that?
Well, the article makes it so brutally clear that a caliber is not a diagnosis, and that merely surviving a gunshot wound is absolutely not the same as getting your life back.
Right, because of that microscopic tissue viability we talked about. The dead bone, the destroyed periosteum, the multi-year reconstructions.
Exactly. If true, functional recovery is dictated by the microscopic survival of tissues that can take years to heal or fail entirely. How heavily is our medical and legal system underestimating the lifetime, invisible costs of these injuries?
That's a great point.
We measure our societal success by survival rates, but how many of those survivors are living with permanent, unseen devastation that the statistics simply ignore because they eventually walked out of the hospital doors?
Wow. That is a heavy, essential question to carry with you. The internet forums will always be loud, the caliber debates will always be noisy, but the reality of human biology remains silent, complex, and totally unforgiving. Keep questioning the slogans you read online, keep looking for the actual science, and keep learning. We'll see you on the next deep dive.